Ladies and gentlemen, welcome to Chapter 9, Articulations and Joints, for the second time, because I recorded this entire lecture and didn't realize that my audio mic wasn't plugged in. So we're going to try again. I am not an online teacher. I don't like this. Okay, moving on. So, let's begin Articulations Chapter 9. Okay. Functions of articulations. Articulations, i.e. joints, where two bones come together. The functions of having a joint. Why do we have joints? Not to smoke in the parking lot, Liz. But, well, that's not a bad idea either. Okay, wait a minute. Anyways. Functions of articulations. Movement. We want movement. We want to be able to move. And stability. Remember, cerebellar functions. Proprioception, where our body is in the world. As we stand, we're always using our counterbalance, right? We're waving back and forth. We're making small adjustments to stabilize ourselves and keep us up. If you couldn't move anything, even if I stood you upright, odds are I couldn't balance you that way. You'd end up falling over, okay? So, functions of joints, or functions of articulations, movement and stability. Now, we classify our joints into two different major categories. We have scientists who didn't know how they wanted to do stuff. So one group saying that they wanted to base it on movement, and another group saying they wanted to base the classifications of joints on the elements that were used to hold them together, the material inside the joints. So the first one we're going to work on is a functional classification. Functional classification means we are basing it on movement. How does the joint move? We have three different categories: synarthritic, amphiarthritic, and diarthritic, okay? So a synarthrosis joint, or a synarthritic joint, excuse me, is classified as no movement, although there is a little bit of movement. One of those joints, if you look, you're going to see a gomphosis joint, which is a fibrous joint, which we'll get into in a little bit. It's a tooth, and you know that your teeth can wiggle a little bit. There is some movement there, but typically synarthritic, it's the classification that says we really don't want any free movement in this joint. We don't want it to move around a lot. You get a couple of millimeters, but you're good, okay? Amphiarthrosis, or an amphiarthritic joint. Amphiarthritic joints have a little bit of movement. Amphiarthritic permits more movement than a synarthritic, but is much stronger than a freely movable joint. The articulating bones are connected by collagen fibers or cartilage. Your tib-fib is your tibia-fibula, where they come together and they're held together side by side. There's a sheath of connective tissue that holds the tibia to the fibula. It's very strong. It still allows a little bit of movement for the bones like this, but it doesn't allow a lot of movement for the bones like this, which is why when you take lateral pressure to your tib-fib region, most times you break both bones, not just one. They're held very tightly together. Diarthritic joint. A diarthritic joint is your freely movable joint. Structural classification is synovial. We'll get into structural classifications in a second. Freely movable joint is your diarthritic joint. This is most of your arm joints, most of your leg joints, most of your body joints are diarthritic, okay? They are subclassified in the directions that they can move. A monaxial means that it can only move in one direction. A biaxial means it can move in two directions. And a triaxial means it can move in three directions or is freely movable. So, monaxial, the elbow, flexion and extension. This only works in one direction, here and here. Biaxial, wrist movement. You get flexion and extension, and you can get lateral flexion and lateral flexion either way. This would also be called abduction and adduction. Abduction and adduction, but we'll get to that. Triaxial, this is three different directions, so you can get all, I got my adduction, abduction, my flexion, and my extension, and my rotation, all in my shoulder. Combined, I can do circumduction, okay? I'm going to demonstrate these a little bit better using my wife later on. We're going to have a guest appearance by Dr. Nikki Edwards. Yeah, she's going to come in and show some flexion extension when we get to that part of the lecture. That way I can operate the cameras and the computer work and somebody can still demonstrate, because up close here, it's just not working. Do you see what my arms and wrists are doing? No, you don't. Okay, moving on. So these are functional classifications of joints. Synarthrosis, amphiarthrosis, diarthrosis. No movement, a little movement, a lot of movement. freely movable. The other classification is structural classification, or i.e. what these bones or joints are made up of. So they're based on the material that's holding the joint together, and whether or not there's some type of fluid-filled cavity that provides cushioning inside that joint. So there's three classifications of structural joints. You have a fibrous, cartilaginous, and synovial. Excuse me, fibrous, meaning it's held together by fibers. Cartilaginous, it's held together with cartilage. Synovial means it has a fluid capsule. It's filled with fluid, and that's a freely movable joint. You will see on page 267, it breaks these joints down. You'll see on the left-hand side, let me get my mouse going, you see your functional categories on the left-hand side, and the structural categories and type in the center with a description off to the side. So you'll see synarthrosis is no movement. At a synarthrosis, the bony edges are quite close together, may even interlock. These extremely strong joints are located where movement between the bones must be prevented. I.e., if the two bones in your skull move too much, you're going to get brain damage! Okay, moving on. So then our structural categories of synarthritic. So we have a synarthritic functional category. Our structural categories that fall into the synarthritic functional category. Structural would be fibrous. We've got a suture and a gomphosis. Cartilaginous, or it's called a synchondrosis, where two bones come together held by cartilage. Chondro means cartilage. And a bony fusion is a synostosis, totally rigid, immovable joint, created when two bones fuse and the boundary between them disappears. This is not really a joint. This is a joint that was a joint in a young little kid, baby, that will harden later on. And you don't have to worry about that one. So moving on. But fibrous, cartilaginous, you're going to want to know those. In our amphiarthrosis, you'll see the amphiarthrosis is over on the left-hand side for the functional category. Structural category, we've got more fibrous, more cartilaginous. We've got a syndesmosis and a symphysis. So this syndesmosis is the fibrous between tib-fib, okay, that we talked about. And then cartilaginous, this is this symphysis right here is our pubic symphysis. This is where cartilage holds two bones together. And then our diarthritic joints, or diarthrosis, are freely movable joints. We see it's broken down to monaxial, biaxial, and triaxial. The structural category is synovial. It's got a synovial capsule filled with synovial fluid. It is called a synovial joint. Diarthritic or synovial joints permit wider range of motion than any other joints, and they're typically located near the ends of your long bones. Like your upper and lower limbs, all right? So most of your limb joints, not your digit joint. Well, no. Let's just go with most all of your joints in your limbs are going to be some type of synovial joint. So synovial joints, they contain a fluid-filled cavity. They're diarthritic, meaning they are freely movable. And it includes all limb joints and most of your body joints. So the most common joint is a synovial joint, or a diarthritic joint. The structures in a synovial joint are as follows. You have cartilage, or fat pads, or meniscus, like in your knees. Okay, you typically have a cartilage that is bound in there for cushioning. You also have hyaline cartilage at the articular surfaces to make sure that it's a smooth transition from one bone to the other bone without grinding. Synovial cavity would be a cavity that covers the whole joint and encapsulates it with synovial fluid, keeping fluid between those two bony structures that are sliding on top of each other. Because if we add a thin layer of fluid on hyaline cartilage, we get a freely movable joint without any friction. Friction is bad. We don't want friction in our joints. Friction in our joints will cause pain when we try to move our joints. This is the concept of arthritis. Articular capsules, the menisci, the fat pads, okay? So some type of articular capsule. There's a little fluid-filled capsule where the two joints come together. Everything is filled with synovial fluid, and then all synovial joints have reinforcing ligaments. Some have a ton of reinforcing ligaments, causing it to be a very stable joint, like the hip, whereas some don't have as many ligaments wrapping around it, and it becomes a little bit easier to dislocate or unstable, like your glenohumeral joint, your shoulder. Here is a picture of your shoulder joint. You're going to see your reinforcing ligaments, the acromioclavicular ligament, the corticoclavicular ligament, ligaments, the coracoacromial ligaments. Here's your coracoid, your acromion, your clavicle. You're going to see this fluid-filled sac all the way wrapped around this joint is our synovial membrane, creating our synovial joint. But the actual articulation between the glenoid cavity and the head of the humerus is only this little bit of a region right here. That's the only articulation there is. Everything else is made up of the tendons that come in from your rotator cuff muscles, your supraspinatus, infraspinatus, teres minor, and subscapularis, wrapping all around, forming what's called the labrum, which helps make this very shallow glenoid cavity become a bigger arc to help stabilize the joint. But it can be dislocated very easily. And again, I said friction is bad in joints. So we have elements that are involved in order to reduce friction in our joints. Those are bursa and tendinous sheets, which is another name for bursa. A bursa is a flat sac with synovial fluid. It is just a fluid-filled cushion, okay? And it's called a tendinous sheath when that fluid-filled cushion is wrapped around a tendon. So here you go. Here's some pictures right here. You've got a subacromial bursa, a bursa that lies underneath the acromion of the scapula, but superior to the head of the humerus, causing a fluid-filled sac between these two joints so they don't rub against each other. Now, on the flip side, you have the long head of your biceps here, and that is going to be wrapped by another type of bursa called the tendinous sheath, and that whole end is wrapped all the way along there, and that's to make sure that as you're flexing and moving your arm, that tendon right there is not grinding on the bone of the head of the humerus. So it helps reduce friction. So, stabilization of a joint. Our joints are directly proportionate to the size of their articulation. Okay? So the less articulation you have from bone on bone, the more unstable that joint is. If you were to try to dislocate your shoulder, there's only a little bit of that glenoid cavity. It's only a shallow thing with a big head of a humerus attaching. So you can actually dislocate the shoulder relatively easily. Whereas in my hip, at the head of my femur going into my acetabulum, I have a big ball for the head of my femur that sits in a big hole, and then it's wrapped and twisted with ligaments. Dislocating your hip, it's such a stable joint, it's very hard to do. Now, I've seen it. I've had a patient walk into my office with a dislocated, limp into my office, still of their own accord, with a dislocated hip. And no, I did not put it back in for them. I sent them to the emergency room because that would be illegal for me. Not that I couldn't have done it, but no, that's not. I could have lost my license. But anyways, the number of ligaments that wrap around it is also a deciding factor about how stable it is. The less ligaments you have stabilizing the joint, the more the joint can be disarticulated, okay? And then the muscle tone. Muscle tone's a big characteristic. If you have really strong muscles in your arm, a lot of times it's that much harder to dislocate your shoulder. You can do it, but it's that much harder. But the stronger the muscle tone, then the more you might have issues with bursa. So there's a give and take with that. But typically, the stronger the muscle tone is, the more stable the joint's going to be. So now we're going to go into the different types of synovial joints. Synovial joints. We have a gliding joint. Movement is slightly non-axial or multi-axial. Examples are the acromioclavicular and claviculosternal joints. So where your acromion meets the sternum and where your acromion meets... Uh-oh. I have an alarm telling me I gotta go do stuff. Because I had to record this twice now. That's why. I'm running behind. Anyways, so where your clavicle attaches to the sternum and where it attaches to your acromion. There is movement where the two bones come together. They're very held together, right? But they can slide a little bit like this, a little bit like this. So they can do that, all right? Other examples are your vertebrocostal joints, where your ribs attach to your vertebra, and your sacroiliac joint. Next joint movement is a hinge joint. Hinge joint is monaxial. This is the elbow. Elbow, knee, ankle, interphalangeal joint. It moves in one direction. And if you try to move it in any other direction, you're going to have to either move another bone or break something. Pivot joint, monaxial. This is a rotation. It's one range, but it's all rotation. This is the part that lets you turn your head between your C1 and C2. There's a lot of rotation that goes on between those bones, between atlas and axis. Biaxial joints. We have a radiocarpal joint, and we have metacarpophalangeal joints and metatarsophalangeal joints. So where the carpals and metacarpals come together, or where the tarsals and metatarsals come together, carpals in the wrist, tarsals in the feet, and the radiocarpal joint, where the radius attaches to the carpal bones. So the radius, it has two movements, right? We have this movement on it, and then we have this movement on it. So that's our biaxial, okay? Biaxial. Another biaxial, first metacarpal joint, one way only. This first joint, only that one. This one can do this, this, and this. Okay. Ball and socket joint. This is a lot of, this is your hips and shoulders. Being able to circumduct, okay? Anterior and lateral view of the pectoral, that says pectoral girdle. Interesting. Pectoral girdle. I've never heard of it termed that way. So it's just talking about the muscles that come up and around and help stabilize the joint. Here is an example of lateral and medial view of your radial ulnar joint and your humeral radial and humeral ulnar joint. And it's just demonstrating you all the ligaments and tendons that are going to be holding that stuff together. Do you have to memorize them? Do you have to know the names of all of them? No, you do not. Here's the hip, the femoral acetabular joint, okay? And it's just showing you how deep it is, how many ligaments spiral around it and hold it together. It's a very, 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 very stable joint, okay? Knee, on the other hand, ton of ligaments. Knees have a lot of things that go wrong with them, though. The joint doesn't typically disarticulate, though. It's a very stable joint for how freely movable it is. But the muscles, the ligaments, and the menisci, all that stuff tears and rips apart a lot. You hear a lot of knee surgeries, okay? Showing you your anterior cruciate ligament, your posterior cruciate ligament, your fat pads, your menisces. All of that's there. You can see it in demonstration. But yeah, very stable joint. A lot of stuff holding it together. Unfortunately, everything gets wrecked down there. Why? Because it carries more weight, right? Okay. Now we are on to joint movements. So, hold on a second. I got to get my Vanna White to come down here. I'm trying to get my Vanna White down here. So give me a moment. Hey, Mama-san! Okay, I'm gonna have to make some camera changes here a little bit, guys. So hold on a second. Okay, I gotta turn my camera around, and I'm gonna have to point it down a little bit. Okay, that's too much. Go stand over in front of my camera, please. There. Oh, great and powerful one. Nope, I don't have any heads on you. Gotta give you some heads. There you go. You love it when I give you heads. Yeah, there you go. Okay. Okay. This is Dr. Nikki Edwards. Wave hi, Dr. Nikki Edwards. Say hi, Dr. Nikki Edwards. There you go. Okay, she's going to help out because I can't run this stuff and do joint movements at the same time. So, we're going to demonstrate, and you'll see in your book, let me find the page. Page 271 in your book, and 274, 275. You're going to see most of these movements in there. We'll try to cover all of them. We may miss one. If we do, you can blame Dr. Nikki Edwards. Okay, so moving on. Let's demonstrate some flexion and extension of joints, please. So we're going to start with flexion and extension of the head. So if you turn sideways for me. This is flexion, ladies and gentlemen. Chin approximating the sternum. Now go into extension for me. All right. That's extension of the head right there. Flexion, extension, turn and face me, please. And then give me some lateral flexions. Oh, yeah, the ditzy blonde looks. Left and right. There you go. Oh. Okay. She doesn't want to do hyperextension for her neck because it hurts. So we're going to do flexion of the antebrachial region, or the forearm. So give me flexion of the forearm, please. Biceps curls. There you go. That's flexion of the forearm. Extension of the forearm. And now we're going to do hyperextension of the forearm because she can do it, and that's sick and gross, and I hate it. Okay, moving on. Can we do flexion of the arm, the brachial region? Flexion of the arm, please. That's flexion. Now extension. You may have to turn sideways to demonstrate extension. There you go. Now back facing me again. We're going to do abduction. Abduction is like abnormal. A-B, meaning away from normal, abnormal, or away from the body. Abduction, to move the arm away from the body or away from the center line. Adduction is the opposite, towards the midline or across the body, like so. So abduction or adduction. Away from the mid-body is ab, towards the mid-body is ad. And that can be done in multiple planes, yes. Why don't you turn lateral for me and give me trunk flexion? There you go. And now extension. And I would ask you to do hyperextension, but I don't want you to fall backwards into the door that's sitting behind you. Okay. Let's do, I'm going to lower my camera a little bit. Let's do flexion of the hip. Okay, so please understand, we are not talking about from the knee down. We are only talking about the hip. That's flexion. Let's see extension. There you go. That's extension of the hip. Turn and face me. We're going to do A-B, abduction of the hip. I would recommend, yeah, watch your footsies. There's abduction. Now adduction would either be bringing the legs together or across the other way. Excellent. Turn sideways for me. We're going to do flexion of the knee. Flexion. No, the flexion of the knee is, now we're not paying attention to the hip. We're only paying attention to the foot coming up. That's flexion. Extension of the knee is, oh my God, yes, standing. Extension is standing. There you go. Okay. Let's get a little bit lower. We're going to look at, hold on a second. I'm getting a little ahead of myself. Oh, my camera's going to fall apart on me. Oh my gosh. I would like you to show dorsiflexion. Dorsiflexion of the foot. So you have your plantar region of the foot, which is the bottom of the foot, and dorsiflexion. Oh, my camera's sliding around. Goodness gracious. Okay, so dorsiflexion, pointing the toes or foot upward. Plantar flexion. Plantar flexion is pointing the toes or foot downward. Let's do some inversion. You're going to want to turn your body so they can see it. Inversion of the foot, or the palm or plantar version of the foot pointing towards the midline is inversion. And then turn it to the outside. This is eversion. Eversion is also known as pronation. And then inversion is supination. But a lot of times that's only referred to as to what your foot does when you walk as far as getting shoes. I'm holding my camera and trying to do stuff at the same time because my camera's being retarded. Angular. Okay, so I want, let's come back up. And we're going to do circumduction of the shoulder. Circumduction. We can go in all directions at the same time. Now, just for fun, let's see circumduction of the hips. Can you do both at the same time? Oh, that's a bummer. Hold on, guys. I got to fix my camera. My thingy's not working the way it's supposed to.
I'm not a marionette.
You're not a marionette. If you were, I'd make you do some things you're not supposed to do on camera. Okay. I covered some of these already. Rotation. You can pick a few joints and rotate them. Oh, there's rotation. There you go. There's some rotation. Can you rotate your trunk? There you go. Rotation. There we go. We did inversion, eversion of feet. We're going to do supination and pronation of the hands. So let's do a supination first. So from neutral, we're going to supinate. Now supinate Supinate is like trying to make a bowl that holds soup. Supination. I want to hold my soup. So that is supination of the forearms. Pronation of the wrists is going to be palms down. I can't hold my soup anymore. Okay? Turn to the side for me. Can I get protraction of the head? She's going to walk like an Egyptian. That's protraction. And now she's going to do retraction. And then while holding retraction, I'd like you to do protraction of your jaw. That's a hell of an underbite. There you go. And then retraction. Oh, yeah, you look real cute there. Sorry. All right. And then the last one I have here is opposition. Opposition, or the opposable thumb, ladies and gentlemen. This is what makes, well, at least you different from monkeys, not me. Opposable thumb, the ability to bring your pinky and your thumb together. That is opposition. All right. Thank you, Vanna. We appreciate you very much. All right. You have a good time. You guys owe her extra money for that, just so you know. She didn't have to volunteer, but she did. Yes, she did. Okay, we are back going. So, in our joints, next thing we have joint problems. Sprain. Sprain versus strain. The P versus the T. You sprain ligaments and you strain a muscle. When you try to lift something really, really heavy, you strain your muscle. When you roll your ankle, you sprain the ligaments in your ankle. You can have a strain and a sprain at the same time, but there is a differentiation between the two. Learn it, live it, love it. Dislocation. We've talked about this before. A dislocation is also called a luxation, and it is the disarticulation of two bones. They no longer attach. It's completely dislocated. If we wanted a subluxation, that would be a misalignment of the bones that is just less than a luxation. Bursitis we've covered. Inflammation of the bursa. Tendinitis is inflammation of the tendon or the tendinous sheath around the tendon. Arthritis. There are hundreds of different types of arthritis. You don't need to know all of them. You are going to want to know you're going to want to know two types of arthritis. This is a classification. You can have acute or chronic, okay? Acute is typically caused by a bacteria or an autoimmune disease. You're having an acute flare-up of arthritis. Chronic is the long-term wear and tear. You've had it for a long time. It slowly gets worse. You address these two things differently. Acute usually means you want to ice it to reduce the inflammation. Chronic usually means you want to heat it to increase fluid in the joint so that it swells a little, gives a little bit more stability. Extra fluid means extra cushioning, and you'll be able to move it. So when you have wear and tear, osteoarthritis in your hands are all arthritic and they hurt. A lot of times soaking them in hot water will loosen them up and make them work better. Whereas if you're having rheumatoid arthritis flare-up, an autoimmune disease, or some type of bacterial infection, then you'd want to ice the joint to reduce the inflammation. Chronic arthritis. So our chronic arthritis is also called osteoarthritis. This is the wear and tear disease. It develops in about 85% of individuals. Basically what that means is as you get older, you will develop arthritis unless you die before you get the arthritis. That's pretty much how it is. Okay? The longer you live, the more chance you're going to get to have arthritis. Its typical cause is by loss of cartilage. So the cartilage starts getting worn down or it gets damaged, and that damaged piece of cartilage now, instead of being a smooth surface, is more like a cheese grater, and it starts grinding other cartilage away, and then next thing you know, you don't have any cartilage left, and now you're bone on bone. Okay? Another arthritis, rheumatoid arthritis. It's an autoimmune disease. Rheumatoid arthritis, earlier onset 40s or 50s. So typically you get RA in your 40s or 50s. And it comes with remission and reoccurrence. My mother had rheumatoid arthritis. She had to take medications that killed the liver in order to keep her flare-ups from getting so bad. She could only be on the meds for a little while, and then once her blood tests came back saying that she had too many proteins in her blood because her liver was now starting to have issues, then she had to take that med. She could be perfectly fine and walk by a table and bump her wrist on the table. And that little tiny bruise, that little tiny bump would cause an autoimmune reaction throughout her entire body. Autoimmune means the body attacks itself. Your immune system recognizes normal material as foreign material. It attacks it, and you have a reaction, okay? So sometimes it's good, and then sometimes it can flare up, and you can have a reoccurrence. All right, that is the lecture for today. Let me minimize this and bring up this. We're going to cover our foot stomps real quick. So if you would like to turn to Chapter 9, first page 266. Basically that chart on 267. Your functional categories versus your structural categories. You're going to want to know the differences there, okay? Turning the page, 268, left-hand side. Synovial joints contain synovial fluid and surrounded by a joint capsule stabilizing structures. I'd highlight that. I would highlight synovial joints, joint capsule, and articular capsule. The components of a synovial joint, the articular cartilage, synovial fluid, fat pads, ligaments, tendons, bursa. I would highlight each and every one of those. Sprain, strain, strains. Page 269, right-hand column, bold print. I would learn that. Page 271, flexion, extension, hyperextension, abduction, adduction. You're going to want to know all of that. You're going to want to know your different freely movable joints, your synovial joints or diarthritic joints on page 272, 273. I would learn those. More actions highlighted. The abduction and adduction, the circumduction are highlighted. Inversion, dorsiflexion, opposition, pronation, supination, all of your directions. You need to know all of your directions. Lateral flexion, retraction, protraction, everything that we've covered. Turning the page, 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 turning the page. That is all of your foot stomps for Chapter 9. That covers you for the next test. Test number 4 will be Thursday. It will be open for 2 hours. 2 hours. It will be open from 6 to 8. Now, that's 120 minutes. That's a little less than 3 minutes per question. I know you all have a book, and you can use your book on this test. But I don't want you to use your book for every test question. So I'm going to open it for 2 hours. You need to start at 6 o'clock on Thursday. Don't be late. Start it at 6 o'clock. I still own you at 6 o'clock on Thursdays. So you will start your test 6 o'clock on Thursday. It will be open from 6 to 8. If anything goes wrong and it's not open and it takes me a little bit to get it open, I will open it from the time that I get it open, 6:30 to 8:30, whatever it happens to be. But it'll be open for 2 hours for you to take. It will be, to the best of my knowledge, all multiple choice questions, so you'll get an immediate grade. Once that test is done on Thursday, I will send out an updated grade for each individual person. Everybody's overall grade went up because you all got a free 50 points on your last test. So I didn't send out an update because really the only thing you're being challenged on is your quiz. So I think the lowest score was a 6 out of 10 and the best score was an 11 out of 10. Okay? But with that being said, test will be right here. You see it. Week of March 3rd. Test number 4, integument, bone structure, and articulations. Test number 4, right here. So that's going to be from 6 to 8. All right? And then we will start, I will post Chapter 10 lectures, Chapter 19 lectures as we roll along, and that will get you ready for the final. The final will also be all multiple choice questions, and I will have you put your extra credit questions in the, well, no, I'll probably just write your I'll just give you your extra credit points. How's that sound? You guys don't mind if I give you free points, right? Right, that's what I thought. So test 4 is on Thursday from 6 to 8. Don't screw it up. Don't go, oh, I was going to go to the movies with my... No, you're not going to the movies. You're frickin' in your house, not going anywhere, and I own you from 6 to 9. Mine belong to me. Okay. So everything's going to be online, okay? So after the test on Thursday, once I've got everything graded and I've got everything updated, I will send you all a text or an email with your current grade, how you did on your test, how you did on your quiz. I'll have all that information in it. Your practicals. So you were doing a skeleton practical. The skeleton practical, if I remember correctly, we said was going to be due like April 3rd or something like that. We're postponing. We are going to make the skeleton practicals due. The skeleton and muscle practical now will be due. I'm going to need some time to grade. I got to watch all of them. So, and I want you guys to know what your final grade looks like before you go into the final. Although the final will be multiple choice. And you'll be able to use your book, so it shouldn't be as bad as it normally is. How about Tuesday, April 21st? Tuesday, April 21st, I think we will be able to make all stuff due Tuesday, April 21st. And then all there will be is your final on Tuesday the 28th. That should work. So we'll go with 21st. Hard deadline, 21st. No ifs, no ands, no buts. A day late is 20% off. 2 days late is 40% off. Actually, no late work accepted. You will have it submitted to me by 6 p.m. Start of class, April 21st. Tuesday, April 21st, 6 p.m. That is the due date. If I don't have it from you by then, you're probably not going to pass this class. And you've had a month and a half to do it. Actually, more than that, right? How much time have you had to do it? When did we came back from spring break, and we had a class, and then everything fell apart. So that was week 9. That was the second week of March. Yeah, you're going to have a month and a half, almost 7 weeks to get it done. Okay? So that's what we're going to do. We're going to make... Now you're going to add muscles to your skeleton. If your particular skeleton project did not constitute the ability to add muscles to it, or you can't figure out a way, that's fine. Just do a separate project with muscles. Same thing. You need to label every single item in a way that I can see you recognize that it's labeled. Do not show me a humerus and then a list of all of the items that belong to the humerus, but not an exact location for each one. You're not going to do well on your final, okay? But that's what we're going to do. So that's going to be worth 150 points. And the extra credit will most definitely... Let's see, there's 3 tests involved in that. There should have been 2 points extra credit for each test. So the extra credit might switch to 6 points instead of 5 points, okay? But regardless, that's there. So that's what we're going to do, ladies and gentlemen. Your projects are going to be due Tuesday, April 21st by 6 p.m. I will grade all of them that week and try to get your updated grades out to you so that you can take your final the following Tuesday, and then I will be submitting your grades Tuesday as soon as you're done with your tests. Okay? I have nothing else for you today. Next lecture will be coming to you next week. I might do it on Thursday just to get it up early. But Chapter 10's coming, then Chapter 19. Chapter 10 and Chapter 19, that'll be it, I think. No, there should be a blood chapter in there. There might be an extra chapter. My schedule might be wrong. There might be an extra chapter in there. I'll have to look into it. But for the most part, make sure you're sending in your homework assignments in a timely manner, and we'll continue from there. Y'all have a good day.